Welcome to this explainer. Today, we're diving right into a high-yield comparison of two notoriously confusing biliary liver disorders, PBC and PSC. Seriously, if you've ever found yourself getting these acronyms twisted up or kind of struggling to remember which one tags along with ulcerative colitis versus Sjogren's syndrome, well, you're in exactly the right place.
All right, let's kick things off with a classic clinical scenario. Imagine you've got a middle-aged female patient presenting to your clinic. She's complaining of this intense, totally unexplainable itching, but when you examine her, there's absolutely no rash. So, what's your first thought? Well, in the right setting, a presentation exactly like this should immediately raise your suspicion for a cholestasis baseline. Here's our roadmap for today. First, the cholestasis baseline, then the autoimmune profile of PBC, followed by the fibrosing profile of PSC. After that, diagnostic workup logic, a high-yield exam duel, and we'll wrap up with prognosis and red flags.
Starting with Section 1, the cholestasis baseline. Before these two diseases diverge into totally different pathologies, they actually share a core presentation as classical intrahepatic cholestasis disorders. And early on, these diseases can be completely silent. In fact, being totally asymptomatic is the most common overall presentation. But when they do become symptomatic, the absolute earliest and most frequent complaint is fatigue, and that's closely followed by severe pruritus. So basically, before you see any skin color changes whatsoever, your patient is just really tired and incredibly itchy. Keep that in mind as your baseline.
Moving on to Section 2, PBC, the autoimmune profile.
Let's build our first diagnostic avatar. Now, you really want to note the critical name change here. It used to be called primary biliary cirrhosis, but it was rightfully renamed primary biliary cholangitis. And why is that? Well, because the core pathology is actually a T and B cell mediated autoimmune inflammatory destruction, and it specifically targets the small intrahepatic intralobular bile ducts. The classic demographic here is just visually striking. We're talking a massive 9-to-1 female-to-male ratio. Typically, this is going to present in a perimenopausal woman, right around her fourth or fifth decade of life. So when you hear about a 45-year-old woman with new onset fatigue, PBC should definitely be flashing in your mind. So the crucial point is how we actually catch it. Get this, an overwhelming 95% of PBC cases will test positive for AMA. That's the antimitochondrial antibody. It's an IgM antibody specifically directed against pyruvate dehydrogenase, or more precisely, the PDHE2 enzyme complex. In the right cholestatic setting, simply getting that positive AMA is very often enough to just lock in your diagnosis. And because PBC is an autoimmune disease, it really likes to travel with other autoimmune diseases. Sjogren's syndrome is the absolute most important clinical association to watch out for here. Though you might also see overlaps with distal renal tubular acidosis, type 1 RTA, as well as autoimmune thyroid disease and even gallstones. All right, Section 3, PSC, the fibrosing profile. Now let's establish our second profile. Unlike PBC, which we just established is inflammatory and autoimmune, PSC is defined by a fibrosing destruction. And this is crucial. It doesn't just hit the small inside ducts. No, it affects both the intra- and extrahepatic ducts. Histologically, you want to look for this really characteristic concentric periductal onion skin fibrosis. It literally chokes the ducts with scar tissue. It's wild. Notice how the demographic completely flips here. We are no longer looking at middle-aged women. Instead, PSC typically affects young males, usually in their 20s to 40s, at a 2-to-1 ratio compared to women. So it is a totally different patient population walking through your clinic doors. Naturally, their clinical associations are vastly different too. 2/3 of PSC patients have ulcerative colitis, and it's often a very specific phenotype, pancolitis with rectal sparing. But here's the really tricky nuance. Treating the UC doesn't magically make the PSC go away. It completely runs its own course. Serology-wise, PSC patients are definitively AMA negative, but they frequently present with atypical p-ANCA antibodies. Plus, genetically, you'll see HLA-B8 and DR3, and the disease is increasingly being framed within the spectrum of IgG4-related diseases. Okay, Section 4, diagnostic workup logic. So how do we actually systematically differentiate these two in a real, day-to-day clinical setting? Well, it's all about an algorithmic approach. Step 1. In any patient with cholestasis, get an ultrasound right away to assess for duct dilation. If you see dilated ducts, that hints at a surgical extrahepatic obstruction. No dilation points to something intrahepatic. Step 2, always rule out drugs. Step 3, if drugs are cleared out, your diagnostic tree branches. If you suspect the middle-aged female profile, go ahead and check the AMA for PBC. If you suspect the young male profile, you're going to order imaging for PSC. And what imaging exactly are you ordering? MRCP. MRCP is definitively the investigation of choice for PSC. I mean, sure, ERCP is acceptable if a physical intervention is needed, but MRCP is the non-invasive gold standard to clearly reveal those characteristic fibrotic strictures alternating with ectasia. It gives you that classic beaded appearance of the biliary tree.
Section 5. The high-yield exam duel. It's time to put these two conditions head-to-head in a rapid-fire comparative duel to really lock this in. Looking at pathology first, the absolute earliest change in PBC is the loss of the canals of Herring that leads to ductopenia with florid duct lesions and non-caseating granulomas. Now contrast that with PSC. You want to avoid overcalling it an inflammatory disease. It actually features minimal inflammation, but a heavily dominant onion skin fibrosis. Therapeutically, they're miles apart. We can actually control PBC pretty reasonably with UDCA, ursodeoxycholic acid. That decreases progression and can honestly even offer some disease reversal. Obeticholic acid is another valid option here too. But PSC is so much more difficult. There's really no effective medical treatment to stop its progression, leaving a liver transplant as the only true therapeutic option. I want you to take a mental screenshot of this master breakdown right now. Seriously, this perfectly illustrates the high-yield contrast you need to memorize. Let's recap. PBC is intrahepatic only, typically older females, AMA positive, linked with Sjogren's. PSC is intra- and extrahepatic, young males, atypical PANCA positive, and strongly linked with ulcerative colitis. If you know this, you fundamentally know the core of these two diseases. Finally, Section 6, prognosis and red flags. Because ultimately, bile failing to reach the intestines has devastating consequences, we have to look at the severe long-term realities here. First up, jaundice. In both diseases, early jaundice is incredibly rare. So if you do see it, it's a late, deeply ominous sign that implies almost complete bile duct destruction. And remember, chronic cholestasis also means fat malabsorption. That leads to deficiencies in your fat-soluble vitamins, A, D, E, and K. But PSC carries an added, really terrifying burden. It's highly premalignant. PSC patients face significant risks of developing both cholangiocarcinoma and colorectal carcinoma. And the difficulty with PSC doesn't just magically end in the operating room. Even after undergoing that required liver transplant, patients face an almost 25% post-transplant recurrence risk. It's just an incredibly stubborn, challenging disease to manage. Thanks so much for joining me on this explainer. I'm going to leave you with one crucial clinical reality to think about. Knowing that PSC is definitively premalignant, while PBC is not, how does that alter your long-term vigilance? Think about it. How will you change the way you counsel and aggressively screen that young male patient compared to the older female patient, just to make sure you stay one step ahead of cancer?